Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it. Hello, everyone. You're back on the Healthcare Algorhythm. Dr. Will Strimel here today, and I am honored to be joined by Jared Torkelson. He is the president of the American Society of Osteoporosis Providers. And this is a disease that is often silent and very frequently leads to significant disability. So I'm really excited to hear about the work that he's doing, specifically around the emerging technologies that are hopefully going to help reduce the burden of this terrible disease. So Jared, thank you so much for making time for me today.
Hey, thanks for having me on. Appreciate it.
Great. So maybe just give me a little bit of a sense of what brought you into this space. And if you could even start with describing osteoporosis. I think we all have a sense of, okay, that means bone loss, but it's more than that. And it probably affects more people than we know about. So tell us a little bit about the landscape of osteoporosis right now, and then your work and what led you to become now the president of the Society of Providers.
Yeah, so I've been a PA in orthopedic surgery now for about 10 years. I started our FLS bone health clinic about 8.5 years ago, 9 years ago, and the stories kind of came from the same place. So a young PA trying to learn the land, figure it out, and you start to notice gosh, we see a lot of hip fractures and wrist fractures in the same type of patients, 65 patients, really older women, some men. And then you start seeing them as a frequent flyer. They start breaking a wrist and then a hip, and then you see them in the spine clinic and things too. So I made that comment one day to the surgeon that I work with. And then that next Monday, there was a paper, the original Own the Bone paper by Dr. Mark Swinkowski, who's the president of Academy at one time, and kind of looked into that and said, yeah, we could, see our hip fracture patients. I can, work them up and do this. This is fine. And then from there it exploded. So, as you alluded to, osteoporosis is very much underdiagnosed worldwide. 1 in 3 women, 1 in 5 men are have an osteoporotic fracture. Historically, the definition, that's a low energy fracture, typically hip, spine, wrist, or shoulder. And it's very detrimental. About a fifth of patients that have a hip fracture significantly lose their independence. The first year after hip fracture, about 20-25% of patients meet their mortality. Spine fracture patients, hip fracture patients. First 2 years, the risk of another fracture is very high. It's tough on the patient, it's tough on the family that's care for them, it's tough on the system. By 2040, the prediction is going to cost the healthcare system, $40 to $50 billion. That's not just the surgery, but that's the cost of the patient, that's the cost of the family taking care of them, that's the cost of the hospital. These patients need a lot of resources, they need our care, we want to give them good care, but they're sick patients, they need a lot of help. So this is it's a burden to everybody, if we can kind of help
And I think a lot of people don't make that connection where you see when you develop that fracture, what you said, I think you said 1 in 5 lose their independence, right? And it's easy to see how heart disease and cancer, those are big events that happen or big diagnoses. But these are often people who are just living their life, don't even know that they are sitting here at risk for this fracture, have a simple, not even a fall, so anything that can happen, and all of a sudden they're disabled. And then, and I think I just wanted to drive home that point. Once you become disabled from a fracture, what does that do to your longevity?
Right. A lot of times these patients already have early onsets of sarcopenia, and they're losing that.
Which is bone loss, but not quite osteoporosis.
Right? No, sarcopenia is more that muscle loss, right? So they're not moving around. Most patients that fracture, that's another great point though, too. Most patients that fracture actually don't have osteoporosis. Most actually have osteopenia. So a lot of times when a patient is educated, whether by the provider or they're just trying to dig around the internet, they say I have osteopenia, I'm okay. It's like, well, those are typically patients that are more active. So if you have osteopenia and you start to fall, that's a big deal. And you got to remember too that for a DEXA scan, which I tell patients there's really only 2 ways that I can diagnose that you have osteoporosis. If we get a DEXA scan, or you fall and you break something.
Yeah.
And if you look at patients 65 plus, especially in women, about, again, 20-25% of women should be getting a DEXA scan, and of those that should be getting it, maybe 10% do.
Right. Why?
So
why is that? What's the barrier?
Yeah, so I think it's a lot of things. I think historically osteoporosis, we really didn't start doing DEXA till the early 90s. If you look at a DEXA scan sheet, I remember when I was in school, I had really good teachers, but I remember the day we talked about osteoporosis and looked at DEXA scans, it was 20 minutes of them fiddling with the screen, trying to figure out what's going on. They say, to be honest, I read the report. I don't really know how to read these. They're really confusing. Within the last 5 years, yeah, it's tough. It's math, right? Math, gross, right? So statistics, nah. But the nice thing in the last, 5, 6 years, just go on DEXA scan reports, they started using colors. It's
Yeah,
just
yeah.
just having a green, red, yellow, basically go, oh, red's bad. Like red is bad. Let's do something about it. And I think a lot of times, historically, the treatment was an oral bisphosphonate, and they had their issues with it too. So patients would trial it, they hate it, and they say, well, that's it. There's a lot of newer medications out there that do a really nice job, but they're expensive. So there's a whole, prior auth process that can be really difficult. My clinic's pretty streamlined. We already have that built in if we're expecting a denial, so we can send out a referral and go on. But if you're a busy family practice clinic or a busy clinic in general, to have that whole process of doing a prior auth and a peer to peer, it takes a lot of effort and a lot of time, and providers are busy. We got a lot of things going on, so that's tough
Absolutely.
too. And a lot of times people, I get all the time. I live in Minnesota, so it's a balmy 9 degrees today, and I'm gonna meet patients this week and next week and the week after that fall and break their wrist, and like anybody would have broke their wrist. And it's like maybe, but let's just get a DEXA scan and see, right? You're due, you're of that age. Let's just do something about it. Historically, women that break their wrist in their 50s, they can break their spine in their 60s and their hip in their 70s. So a lot of people don't even put
So then
that.
the wrist, is that the canary in the coal mine kind of
That's
thing?
the one. Yeah. Yep. And again, easy to have a wrist fracture, right? That's a good thing too. But if you're of age, that brings a risk in. That's maybe you just get a DEX scan and see. If you're still okay, fine. If you're in that osteopenic or osteoporotic range, let's talk about medication. Let's talk about lifestyle factors. So having a good bone health clinic, yes, a big part of it's medications, and I do a lot of that talking too and educating there too. But it's also, are you falling a lot? Do you need a walker or need to get a cane? Should we start an exercise program? Do we want to talk about your diet? There's a lot of things there too. The bones are kind of the redheaded stepchild of the body, saying that as a redheaded person. The heart gets what it wants, the lung gets what it wants, the bone kind of is there at the end, and if the body needs something, that's where it gets stripped from. So we got to think about those things too. So resistance exercises, we talk about that a lot, walking, getting around, and moving. It's
Yeah, I mean, that's
really
so it's so
encompassing. It's a
important
whole
for
health
every
thing.
disease process, right?
Yeah,
Staying active is
yeah,
one of the
yeah.
core things of a long life. Now, when you use those age ranges, you mentioned women, and of course, we typically think of this as a woman's disease, but it's not just women, right? And
No.
I think men don't even have this on their radar. They're tougher patients to begin with, speaking as
Hmm.
one,
Yeah.
but men don't. We don't realize there is an absolute burden of osteoporosis in men. So maybe just
Abs
talk about that a little bit.
Yeah, absolutely. Worldwide, 1 in 5 men are gonna have a fragility fracture, right? And again, also as a man too, you fall and break something, like I'm fine. Let's rub some dirt on it. We're good. You know, if you're a man that's 7 years old or older, you should get a DEXA scan regardless. I mean, that's when we should start just doing screening with DEXA scans, looking for osteoporosis. If you have risk factors, if you have modifiable risk factors, are you a smoker? Are you diabetic? Do you have heart disease? Then you should be talking to your doctor about maybe getting a DEXA scan and getting that workup. If you've had a fracture, then we got to talk about doing some treatment. But very much that's not something within the male community or people identify as male that's talked about. So I live in a smaller community within Minnesota. It's a big rural community, so having that talk of with old farmer guys that have a hip fracture, or spine fracture, like, well, no, women typically get that. Like, no, men do too. Let's talk
Right.
about this a little bit. So that can be a big thing too. But absolutely,
Now,
men can get osteoporosis.
you've mentioned the DEXA scans a lot, and so DEXA, and I want to give you a chance. Number one, just explain that for the person who's never heard one, what that is. But that's the foundation. It seems like of screening slash diagnosis. But then let's talk about: is there anything else on the horizon?
Yeah, yeah. So historically, it's been DEXA scans that we've used since it's early '90s. It's a dual X-ray. It's kind of a weaker X-ray, is how I explain it. And typically, you're going to look at the lumbar spine, and then your dominant hip. Here we look at both the hips, but the dominant hip, and then plus or minus your distal radius. And there you get something called a T-score. And if you remember back to statistics, that's a sampling size. And then we're looking at two standard deviations off. So your bones are never sitting there. You're always making bones and breaking them down. When you're young, you make them very fast. When you're older, you break it down a little faster, and you peak at about 30. And really, all we're trying to do is that what bone loss have you had since 30 years old, or we assume that you've had. And if you've had too much, we call it osteopenia or osteoporosis. So it's a big bell curve, is all we're looking at. So that's what T scores are. So there, fun fact for the day. DEXA scans are really tough. They're really tough because they're only calibrated to themselves, meaning that if you get a DEXA scan, you come to my clinic and I see you and you get a DEXA scan on my machine, and then let's say 2 years from now you get it on a different machine, I can kind of make inferences, but I can't tell you you've gained percent or lost this percent of bone because it's only calibrated to itself. Plus, it's also tech determined. So here at my clinic, we have really good DEXA techs. I'm really privileged about that. If you have a tech that maybe doesn't do a lot of them, if they're dual board exam, doing general X-ray and maybe mammography and a DEXA scan too, and they don't do a lot, and then there's kind of little tips and tricks and things that you
There's
have
some
to follow through.
nuances
That
into the way it's
Yeah,
performed.
if you don't do those, that can throw the scan off quite a bit. one of the areas you look at is the femoral neck, and the femoral neck isn't a cylinder; it's actually oblong. So, you're looking at it like this. So if you rotate the hip, it's either thicker or thinner. That can throw your scan off quite a bit. If you have significant arthritis in your spine, that's going to throw your scans off as well too. We get patients now, younger and younger, getting hip arthroplasty. My other job is I work with a busy lower extremity hip and knee surgeon. So if you have a patient, you have both your hips replaced, and you got arthritis in your spine, or you have arthritis or something on your spine, we may not have any place that we can look at anymore, which makes it tough. We can look at it at wrist a little bit, but those are tough to interpret. So in the last 15 years, we started looking at opportunistic CT, which has kind of been the big field shift. And all that is that how many CT scans are out there, right? You go to the ED, you have abdomen pain, they're going to CT scan looking for something. So all these CT scans are sitting there. So there's a group
Right.
over at Wisconsin that said, let's use this. So now we can actually measure a Hounsfield unit, and that's just basically how bright or how dark it is on your CT scan, and we can diagnose osteoporosis based off that. And that's been huge, right? Because if you're coming to see me in clinic and I got to get you a DEXA scan and it takes a month to get in, if I have a CT scan now, I can treat you now. We also use it a lot in our optimization patients, especially our spine optimization patients. If you're getting a 3-level fusion or a 5-level fusion, I can look where that screw is going to go, that pedicle screw is going to go, and say this bone's bad. We need to get you on an anabolic. And typically those are showing worse scores than what a T score is. They're looking at there too. So we use those
Now,
quite a
are
bit.
traditional CT scans being interpreted in a way that you'll get this data readily, or is there some other platform that has to be involved to go back and look at these scans and quote unquote rescore them?
No, no. So basically, I pull up the scan up. I make a little viewing window that tells me the ounce unit's right there, and then that's it, done. Save it to the chart. Some places I know I've trained the radiologists to do that. I know some spine centers have. Radiologists are very busy here, so it takes me 3 minutes. I do part of mine. But that's where a lot of the emerging technology is coming in right now. So AI is big. AI is everywhere. We're using it. Every clinic, I think, in the country is starting to use it too, which is great. It's taking a lot of time. I'm a big fan of ambient AI using for my notes, but a lot of the companies right now are using that for finding these CT scans. They're building in platforms where they're putting AI in to go out to find these CT scans, make that measurement, and pull it up right away, which is fantastic.
Wow. Okay.
It's a blessing and a curse because you're finding more patients out there that have osteoporosis, which is something that we know about. When I talk to people that are starting bone health clinics, your clinic's not going to fail due to lack of patients. It's going to fail because you're going to get overwhelmed and lack of resources, right? So this is a flood of patients that are out there. So, which we need to see them, we need to treat them, but we need more providers to be treating these patients. And that's where I think AI and emerging technology needs to go next. We have these technologies to diagnose these patients, which is fantastic. We have algorithms that can go out there and find these fracture patients that have been missed, because there's a big disconnect where if they come and see me for hip fracture and I say, you need to go talk to primary care, your endocrinologist to get treated for this, they kind of get lost in the shuffle, right? People are busy. There's a lot going on. They just had one of the worst days of their life breaking their hip. Now they have to remember to see an endocrinologist. What's an endocrinologist? What are they going to do?
Sure.
So most successful clinics like mine, we house it within orthopedics. That way we can capture that patient and keep that patient. But there's not a lot of me out there. There's not a lot of endocrinologists out there. You're not going to get an orthopedic surgeon that's done 5 years of residency and a fellowship to do non-operative treatment. A lot of residents coming out right now in orthopedics understand this is a big deal. We need somebody to do this. This has actually been a really good place for advanced practice providers to come in and fill that gap. But we need to start looking at AI as a diagnostic tool. Can we use that where if you are a family practice clinic and it's an hour and a half to the nearest hospital, can we do something to help that person or to enable that person to make these treatment decisions of using these anabolic medications to treat these patients
So what would
faster?
that look like? I mean, from your from your perspective,
Yeah.
because at the end of the day, artificial intelligence is really just taking all information that's out there and leveraging it, right? And
Yeah.
being able to act on it. So what's the low-hanging fruit that you would see? And I'm saying that as if there's someone listening who's a developer and they're looking for a space to get into, here's your chance to pitch them on the
Yeah.
problem.
Yeah, right. So AI is a tool, right? You can't have your strategy can't be implemented in AI, right? So your strategy has to be how can we treat these patients and how can we use AI to do that? So the data is all there, right? So if you have something that can compile that data to there, that's going to look at the patient's past medical history, it's going to look at the patient's social determinants of health, it's going to look at their DEXA scans, their CT scans, and maybe their past medical history, maybe they've already fractured, pull all that stuff in together too, and say, look, your risk of having a fracture is, so what are we gonna call that? We use something called FRAC score, which was developed in Europe, where it takes a lot of your past medical history, your DEXA scan, and it gives this number. And based on this number, we should treat you or not treat you. Do we need to take that the next step by making some sort of number or some sort of stop line saying this patient needs treatment, this one doesn't, based on all this medical information on somebody that may not be, you know, um, as well versed in osteoporosis, right? So we're thinking more of if the primary care provider or people that kind of do osteoporosis a little bit, blah, blah, other things, can we build this tool of that AI to predict it? A lot of places out there building predictive AI tools. We're one of them. So we're taking data. We're going to build a language model to say, based on your medical history right now, your risk of fracturing in X amount of years is this, right? And this is based off of data, data, data. So I think that's where a lot of this is going, which is
Well, like
nice
you
because
said, that does certainly makes the diagnosis and the awareness, it raises that, but
mhm,
then there still becomes a bottleneck, right? And so I think that's probably the
yeah,
next layer is how do we reduce the bottleneck of then taking this awareness and translating it into ideally effective strategies for prevention,
yeah,
right?
yep. And that's where a lot of this is like, so it's going to say, can we, it's always been secondary fracture prevention, right? So the patient's fractured, how do we prevent the next one? I think AI can be that tool that says, how do we actually prevent the first one?
So I would imagine that ties into the work that you're doing with the Society for Osteoporosis Providers. So maybe
Yeah.
share a little bit about that organization and what you're focused on.
Yeah, so I have the privilege of being the president of the American Society of Osteoporosis Providers. So it's a lot of providers that are in this field of osteoporosis and have found a lot of these problems and try and do something about it. So there's a lot of niches out there. There's some that are more patient facing, more that deal a lot with pharma. We've kind of said, look, there's kind of a big gap on education for the provider. There's a little bit when you start, they kind of leverage on you, maybe learn something with your training, and then you started off, that you get into practice, kind of do things. But there's a lot of people that like, I just need something in the middle, or maybe they find osteoporosis later in their career and they need to go back and have some sort of certified body. So we said, look, can we build an education platform with a certification and say, look, you're going to get this many CME. Here's a whole course where you can get into the nuts and bolts of osteoporosis. We're very lucky to have very well-known people within the osteoporosis space to help us curate this educational treatment and say, look, you can take this test, you can learn this education from us, and really be an expert in this field and also stay up to it, right? So there's not a lot of continuing CME there too. And plus it just kind of creates a community. I was very privileged that I randomly had a lot of connections with osteoporosis, and now I know patients or people all over the country that are doing this too. But if you are in the middle of nowhere, Nebraska, and you're trying to start a clinic, which is great, you may not know anybody. I have somebody that lives an hour and a half up the road that say, hey, this is weird. What do you think about this? And I can just text them. But if you don't have those connections, it's tough. So we can build off that too. But the big piece is, can we educate patients out there or educate providers out there to treat more patients, to help with that primary fracture prevention and secondary prevention?
Okay, so I imagine you can have a ready to go toolkit, so to speak, for someone who wants to get in there by the best and the brightest. Right?
Yep. Yeah, so we have the educational piece. We're working on a platform as well too that say, this is how we would recommend you building your clinic and going those things, but really
Right.
getting the nuts and bolts and say this is how you need to do it, and we're here to help. We want to help you.
Well, that's great. So, I like to kind of head towards the close by bringing this always back to the patients. Excuse me. And, with all the precision medicine that's out there, personalized medicine, you mentioned that bone loss really starts at age 30. So I think I would like to think we have a lot of younger people who are getting more engaged, especially with the technology that's out there
Hmm.
to understand more about their health. So maybe let's start with the patient in their 30s, that range. What should they be thinking about? Or, they hear this, hey, what are some simple steps they should look at? Is there technology that tells them things they personally should do? Are there supplements? Just what do you do at age 30 to prevent this from happening?
Yeah, yeah. So I'm a big proponent, keep moving, right? So I think exercise is key. 30 minutes a day if you can, or at least 2 to 3 days a week, and then do something you like doing. Things that people don't think about. There's really good evidence out there that Tai Chi is good for your bones, right?
I've been seeing a lot of Tai Chi advertisements lately.
Yeah, yeah, which if you're into it, great. Not my thing. I like to cycle, I like to lift weights, but if you can stay active and keep active, bones like contact, bones like to move, your bones will stay strong. You keep doing those things. There's a quick low hanging fruit, right? The smoking and those types of things too. I think people get that, but
Sure.
but activity's big. Having that good diet, protein's a big one there too. Those are all the big things with it. And talk to your parents, right? So talk to your mom, your dad, your family, and say, is this in our family, right?
Okay.
Should I be doing that? What is your medical history like? Are you diabetic? Do you have heart issues? One that we find a lot of that don't think of is patients that go through bariatric surgery. Talking about GLP-1s a lot, that rapid weight loss. If you think of that's a lot less force on your body. I've seen a few patients but they start having fractures after rapid weight loss after GLP-1s, but
Wow.
also there's less of you, right? I think it eventually comes back because these patients are active, but within that first year or two or so, there's just less mass. The bone goes, oh, I don't need a lot more of this stuff. So we're seeing those there too. So
Interesting.
staying active, knowing your medical history, knowing your family medical history, and just trying to stay healthy as long as you can. Keeping
Anything in
muscle, keeping
particular
bone.
around supplements that are out there? I mean, I'm not asking you, to kind of recommend any brands or anything, but, should people think
Yeah.
about, hey, if you have this in your family, you should have more intake of this in your diet, let's say?
Calcium, vitamin D are the workhorses that I discuss. We shoot for about 1,200 milligrams a day, and that can be with food or supplements. If you have a lot, that's great. I tell people there's more calcium in a cup of milk or a cup of broccoli than a cup of milk. Green leafy vegetables are great for that too, so that's good. And then vitamin D. If you want to start taking a 600 milligrams of calcium, and then with usually 400 IUs of vitamin D3, that's a fine place to start right there.
Okay, great. So how about now, kind of on the other end of the spectrum, you've talked about secondary prevention, or, let's even get into the at-risk population or some secondary prevention. What can patients and specifically their families, what are the barriers
Mhm.
that they're facing? What are the steps that they can do now to reduce that to prevent this from coming a disability?
Yeah, absolutely. So I think those things help too. So stay active as long as you can, right? So you don't have to be bodybuilding at 75, but doing chair yoga, staying active, silver sneaker programs are great. Again, supplements are great too. I think keeping track of what you're eating as you get older, and increasing those protein intakes is big. And fall prevention's huge, right? So are you something that's prone to fall? Are you noticing weakness in your lower body that you're tripping? And do we have rugs? Do we have things on the floor we need to move? And then having that real conversation of, do we need to use a gait aid? Do we need to use a cane, which isn't fun. And I think a lot of people take that as a sign of like, gosh, I'm getting old. But if that's what's
Mhm.
keeping you safe, and I say, if this is what keeps you at home, use the cane. That's okay. We want you at home. When I speak around the country at various things, I say I still take calls. I was on call last night. We still see hip fracture patients. I have gonna the next morning say, you've had a hip fracture. We're gonna fix it for you. I've never had a patient tell me they're afraid to die. I've had numerous patients tell me they're afraid that they're never gonna go home.
Absolutely. That's huge. All right. And so these little ounces of prevention can go a long way to keeping people independent. And I think that's
Absolutely.
what we all strive for as we age. So if someone's out there, they're more interested in learning about osteoporosis, what they can do, where would you point them?
Yeah, so at the ASOP, the American Society of Osteoporosis Providers, that's our website with great tool. There's a lot of other organizations out there, but I think most importantly, talk to your provider. Having that conversation early is a big piece with it too. Talk to people that you know, get moving. Those are the big ones with it.
Okay, well, that's fantastic, Jared. Thank you so much. And what I would say is, if you, as you see new technologies, whatever the next best, greatest thing, but after the DEXA scan, I'm sure it's probably coming down the way. Please let us know. Keep us connected. But I really
Yeah,
do appreciate your time tonight, especially being on call last night. I know how that feels.
yeah, yeah. Coffee helps.
Amen to that. All right, and thank you everyone for joining us. We'll see you the next time on Healthcare Algorithm. Until then, be well.
Thank you.